Well, first of all, I would like to thank you, Dr. Baloglu, for inviting me and all the other of the organizing committee. It's a great pleasure for me to be here. I think I'm now the fifth time in Istanbul, but I have never spoken to Istanbul or Turkish pathologists. So it's a special honor for me to be here today. And I would like to try to bring the new development of our specialty a little bit closer to you, to explain what we means our society in Germany, but also in all the other European countries, and I think in particular also in Turkey, what we think will be the future of pathology. And it's very important that we as pathologists understand what is the development in the future, and I will try to bring this closer to you today. Introduction to this course. I think that we always have to check and to face also a, let me say, political issue. What is the main challenge in anatomic pathology? What is the main goal of our diagnostic work? This is to extract from the patient's tissue as many information as possible. And we should not limit ourselves only to morphology. This does not mean that morphology isn't the basis of all of this. And it's very important, and we need it, and we need H&E and PAS and all these, but we shouldn't limit our activities to, let me say, only this morphological basis. To improve our possibilities to understand the disease and to take the tissue, which is very valuable, take the tissue from the patient, we should use, as I have shown here, yeah, a little bit. Classical morphology, immunological, and molecular techniques. We should combine them as a whole, or as a holistic diagnostic procedure. But basically, it should not be forgotten, and this sentence is more for the clinicians, that the methodological results have to be interpreted as a whole. You cannot have only immunohistochemistry or only molecular. You have always have to see it as a whole procedure, and this has to be interpreted by a pathologist, by an experienced pathologist, or by a group of pathologists to really assign the difficult and different characteristics to the individual disease. One special part which becomes more and more important is predictive molecular pathology and personalized medicine. More or less for the first time, the duty and the challenge for pathologists are changing. That means we do not do only the diagnostic. We don't say only it's a colorectal cancer, but we say what should be the treatment. And this is a totally different approach to all these activities we have. And we do this, and this is the reason why it's in red, therapeutically. That means before the clinicians decide whether to give Herceptin, for example, in breast cancer or not, we have to analyze HER2 or receptor. For this prediction, we need reliable and reproducible biomarker and predictive assays. And the challenge for us is to standardize these processes, to have it around all our institutes, get the same results on the same tissue, which is not always the case. So I think we are in a position that we have to fight for this, and we really have to, I will mention this later on a little bit more in detail, we really have to understand that the challenge and the demand of the clinicians and of the patients, of course, changes during the last couple of years. Prediction is difficult, especially about the future. This sentence by Niels Bohr is certainly true, but when we are thinking back on infectious diseases and seeing the current development in cancer, we shouldn't be too pessimistic. Infectious diseases, I mean antibiogram, for example, it's a typical predictive procedure, and then you can say whether this or that drug will help against this or that microorganism. When we now see HER2, KRAS, BRAF, EGFR, and there will come others, then we are in the similar situation. And the predictive power, and I'm quite convinced of this, of tissue-based analysis is still underestimated. And in the next 5 years, 10 years, there will come up just one word, next generation sequencing, for example. There will come up a lot of new techniques, a lot of new possibilities to get more information out of the tissue. This is only a short list of those tumors and those drugs which at the moment, at least in our institute, is already treated in this way. That means there is an eligibility test, which normally is approved by the FDA or the EMA, the European FDA, and it's necessary pre-therapeutically to, for example, before you give trastuzumab to metastatic breast cancer, you have to, of course, analyze the HER receptor. Cetuximab, panitumumab for colorectal cancer, gefitinib, erlotinib, and very new, only since 1 year, crizotinib in non-small cell lung cancer, and there are some others. I don't want to go through the whole list. I will show you some examples later on. Maybe I would like to mention one. This is vemurafenib against malignant melanoma, very interesting BRAF inhibitor, but you have to analyze whether BRAF is mutated, yes or no, prior to giving this drug. So in our institute, and I think it will be the same here, already approximately 35% of all new cancer cases are related and associated with a predictive molecular test. So this is not a rare event. It is becoming more and more routine, and I think this number will increase to 50% or even more in the next years. To follow these possibilities, to follow these and to improve these procedures, one very important thing has to be considered. We need human biobanks. And Georgia, I think you will speak about this issue later, is one of the heroes, let me say, of biobanking and of the organizing this, because all the development which we saw is based on human tissue. There is, of course, at the beginning cell culture, then animal models, but finally it must be shown and proven on human tissue, and this underlines the importance of biobanks, well annotated biobanks. Well, what is the normal procedure regarding personalized oncology? This, of course, is a multidisciplinary cooperation, but it's not possible without pathology. So starting with the patient, of course, there is the oncologist, there is the diagnosis, the targeted therapy are considered. Then there should be a tumor board. It should be, at least in theory, for all tumor patients. Whether this is reality and whether this is possible is another question. Then the sampling is doing. Then a step which becomes more and more important is pre-analytic. I will speak tomorrow a little bit about that. Pre-analytic means the parts or the time frame from taking the tissue out of the body to the Institute of Pathology. When this is on Friday evening and the fixation is suboptimal, you get a totally different result as if it's Monday morning and it's fixed immediately and you get it 2 hours later in your institute. So we as pathologists didn't really recognize these problems in the last years, so we are more and more becoming aware of the situation that we have to standardize this process, and as I told you, we can speak and discuss this tomorrow morning. Predictive biomarkers was the topic of the day, and then there is a result, and then there is a decision what to do with the patient. One point, I just discussed this with some colleagues this morning, but it's a strong discussion in Germany, and as I've heard, also in Turkey there is a dispute, let me say, between pathologists and human genetics. This is who is doing this, because simple sequencing, of course, can do everybody, more or less, who has a molecular lab. But this is too simple. And this is the reason why I always emphasize what is the irreplaceable role of anatomic pathology. Why are we the key of this? I think you know it, but you have to explain this always to the clinicians. you all know the normal tumor resection, grafting, histological evaluation, but there is one new step in the procedure now, and this is what we call manual microdissection. This is absolutely important and crucial for a correct and reliable and reproducible result. What is manual microdissection, or what do we understand under this? Oh, there's one slide missing. Okay, what I want to explain is that we have to select the material out of the biopsy. If you have a biopsy from lung cancer, for example, you often have 5 biopsies with normal or necrosis and only 1 with tumor, and you have to select this material from the paraffin block very precisely. I will explain this tomorrow. This is the reason why it's not here. What are the entities which I would like to focus today a little bit? This is colon cancer, non-small cell malignant melanoma, breast cancer, and what are some upcoming changes. Invasive colorectal cancer, you all know this. There are 2 new drugs which are allowed to give to the patients only if the pre-therapeutical eligibility test has been done by a pathologist. This means that we have to check whether the EGF receptor is functioning in a correct way or not, because these are therapeutical antibodies, so they are going on the outside of the cell. What was a basic study which showed that this pre-therapeutic analysis is important? This is shown by this slide. You see the blue curve. This is panitumumab, but only when it's a wild-type KRAS tumor. If it's mutated, you have it down here. So the stratification of these 2 lines, the difference of these Kaplan-Meier curves, depends on the proof that there is a wild-type KRAS in this first step. Why is it like this? You have the EGFR receptor here. You have the ligands, which normally stimulate the receptor, which in many tumors is overexpressed. But when you give the drug, you have the antibody here on the outside, and they are blocking the EGF receptor so that the stimulation couldn't happen. And the pathway, EGFR, KRAS, and then the normal RAF-MEK-ERK pathway to the nucleus, is stopped, and by this, the signal grow is stopped. So the tumor is reduced, at least in the potency of growing. However, in approximately 50% of all colorectal cancer, we have a mutated KRAS, which means that there is a constitutively active KRAS signal-giving molecule, which gives signal to the nucleus. And it doesn't make sense, absolutely doesn't make sense, to give here the drug, which by the way costs 30,000 euro or something around that, to block the EGFR receptor when the signal is coming from inside the cell. So this is again the necessity to analyze this tumor. And there are new things now coming up, and this has been at the last ASCO, they have been reported. We have to sub-analyze, not only mutation, yes or no, but we have to know whether it's a 12 or a 13 mutation. 61 is very rare. What is the reason? The relevance of different types of KRAS and RAS mutations and BRAF, I will show you in a second. It has been shown that KRAS, BRAF wild type has a median progression-free survival, for example, of 8 months. KRAS mutation codon 13 is similar. There is no significant difference. Only the KRAS mutation codon 12 seems to be the oncogenic driver. So it's helpful or necessary to analyze which mutation do you have. And what was shown also is that if you have a BRAF mutation, it's even worse. So it becomes more and more necessary to analyze the tumor very precisely. You can skip this. The BRAF, for example, is shown here. If you have a BRAF mutation, this is the yellow line, the Kaplan-Meier curve is much worse. BRAF is a prognostic marker, KRAS is a predictive marker. The consequence out of the BRAF inhibitor, out of the BRAF situation would be to give a BRAF inhibitor, for example, femurafenib. The problem is clinically there was no efficacy. Why? There's a very nice paper of Prahalabat which have shown that if you block in colorectal cancer the BRAF pathway, the mutated BRAF pathway, the cells are able to stimulate and to increase the presence of the EGFR receptor. So this is a collateral process that gives the cell the possibility to survive, although there is a BRAF mutation, there is a BRAF inhibitor, BRAF is inhibited, but the EGFR pathway is working very nicely. Why do I explain this to you? Because the next step in targeted therapy will be the combination therapy consisting of BRAF and EGFR inhibitors. So it could be that the combination of these two targeted drugs can become a very important issue. And this will be the challenge of the next years. The studies are going on. There are first clinical studies around this. So we will see what happens, whether the combination of two targeted drugs may be even better for the patients. There was a second point, which came up this year at ASCO. In colorectal cancer, as I showed you, and everybody knows, there is approximately 55% are KRAS wild type. So these 55% wild type should be sensitive for panitumumab and cetuximab. However, out of these, only 50% really responded. That means there is a group of tumors which are wild type for KRAS. I have to be precise, codon 12 and 13, which was analyzed normally, but they do not respond. And nobody really knew why. How can we detect, how can these group of tumors, which are so-called, I have to say, wild type, but which do not respond, how can we stratify them? How can we detect them? And what was shown is that up to now, we only detected 12, 13 because this is the highest number of mutations. But we missed, or we didn't analyze, KRAS, exon 3 and 4, and we forgot NRAS. All these together are 17%. And it became clear that the tumors, which also have, for example, an NRAS codon 3 mutation, also do not respond. So now it became possible to stratify the colorectal cancer patients even better, because these 17% are also excluded from the therapy, which of course enhances the efficacy of the drug. That this makes also from the biological point of view makes sense is that these RAS genes encode for a highly homologous protein. So the proteins which are encoded are similar, so it makes sense that these mutations regarding RAS are also important for the efficacy of the drug. Very shortly, this is the old KRAS curve, and this is now the RAS curve. You see the difference, it's not very high, but it brings both curves a little bit out of separated better, and this is for the patients, it's approximately 6 months. So it's not negligible. Okay, coming to the next tumor, which is very interesting, and from a pathology, molecular pathology, a lot of things happen. This is a non-small cell lung cancer. And you know that there are very effective tyrosine kinase inhibitors which can be given when there's a special molecular structure in the tumor. In the 90s, end of the 90s, the pathology only has to say, is it an adenocarcinoma, squamous or large cell? This was enough for the patients. and for the clinician, so it was relatively simple. Today, 10 years, 12 years later, with all these targeting oncogenic drivers, we have a totally different situation. We have to analyze the tumor regarding KRAS, EGFR, AML4ALK, and others around here, whether the mutations are present or not, to give the right drug. And I'm quite convinced that also a tumor, which is rare, but it happens, which has HER2 positivity, can be treated with Herceptin, although it's a non-small cell lung cancer. And they were coming up many others, and also this group will be analyzed in the future more and more, so that rare mutations will play a role. At the moment, the major two are the EGFR mutation testing for non-small cell lung cancer and the ALK fusion gene, which is for crizotinib. Very shortly, gefitinib, which is one of these tyrosine kinase inhibitors, and you see when there is a mutation, when there is a special mutation in the EGFR receptor, you get this positive curve. If not, it's down here. So prior to the therapy, again, you have to check whether there is a EGFR mutation. Why is it like this? The drugs are inhibiting the kinase domain of the EGFR receptor. And this only works when there is an activating mutation of the EGFR to overexpress the kinase inhibitor. And then it's blocked. So again, prior to the therapy, you have to show that this mutation is present, and if not, you're not allowed to give the drug. You even harm the patient, because the curves are even worse when you compare it with normal chemotherapy. So it's an absolutely necessary prerequisite before giving the drug to do these analyses, which exon shall be tested very shortly. At the moment, and at least our suggestion is to test all four, 18, 19, 20, and 21. Sometimes it's not necessary to do 20 if you want, because it's very rare, but we are doing all four also to get an overview on the tumors. Based on the experience of more than 3,000 cases, now we strongly recommend, and this is a general recommendation of the German Society, to test all four exons. This is what I said up to now was gefitinib and erlotinib, which are more or less the same. And I would like to stress a new one, crizotinib, which is coming up, which is approved. I don't know in Turkey. It's already approved. Yeah. With these drugs, you sometimes see effects which are absolutely fantastic and which you have never seen in earlier times. For example, here, in a relative short time, when there is AML4 ALK mutation, you see that these metastases more or less disappear. Of course, the patient will die from this disease. We should be too positive, but nevertheless, the first time we have a possibility to induce changes like this. I will show you later an example for malignant melanoma, which is very similar. When the mutation is there, most of the tumors, the vast majority, is reacting to studies which show more or less the same. So it's absolutely important to have these possibilities. What is happening on the biological level? You see here the AML4 when they are normally, they control each other. But when in the tumor there is an inversion, it's not a clear mutation, it's normally an inversion between ALK and AML4, then we again have a constitutive activation of this pathway, and the cell gets the signal grow, grow, grow. What are we doing? We have to do it with fish at the moment. This is a gold standard. We don't like it very much, but it is like this in the moment. And if we have a normal situation, you see it here, we have a green and a red signal in the middle, and there is a yellow mixed color. If there is a mutation, the inversion, these 2 points are different, or these 2 signals are different. You see it here. Here is a correct chromosome, this is a mutation. they are separated. There is signal, one red only signal, this is also possible, same around here. So this is the approach which at the moment is done in non-small cell lung cancer. So there are two or three possibilities, two or three drugs which have, where is the necessity to have this pre-analytic analysis. Malignant melanoma, also very, very impressive. 50% have a BRAF mutation. And you know, again, the same curve, when there is a mutation, then you get a better result. Let me show you some examples. Patients here, this is tumor, it's reduced, can do it like this. It's a dramatic result, what you never ever have seen in earlier times with the normal chemotherapy. Or here a young lady which has these malignant melanoma in the skin, and it more or less disappeared. She has had a BRAF, or the tumor has had a BRAF mutation, and she was treated with this drug. So it's really impressive what's happening, and it's a chance to get an improvement of our possibilities to treat cancer. What is the biology again? RAS-RAF-MEK-ERK is the normal way. 50% have these mutation, and there is a drug which inhibits this. In particular, the BRAF mutation, the signal which is coming from these mutated BRAF. But we know that after a couple of months, the tumors became resistant, and we have the possibility to inhibit now on a second level. This is again a combination of two drugs, two targeted drugs, which may improve, and this is the next slide, which improves again the overall survival in this case for a couple of months, which is a dramatic effect in metastasized malignant melanoma. Again, this combination drug is very interesting. The next step in our development regarding molecular pathology are so-called multi-gene assays. I can go very fast through this. Up to now, at least in US and in Europe, we have two assays. One is Oncotype DX, the other one is M Dietel, which are able to stratify patients with an ER-positive, HER2-negative breast cancer, whether they should get only tamoxifen or tamoxifen plus chemotherapy. A difficult question for clinicians and patients. This is also recognized in the new WHO classification. Prognostic and predictive gene expression can be used in clinical practice. This is the first time that the WHO accepted this. And very shortly, I don't want to go too much into details, but following this EndoPredict, in which development we have been involved, predictive data, the 96% of the patients who are from the pattern of molecular analysis are low risk, do not show up with metastasis after 10 years when they are treated only with tamoxifen. So you can avoid for the patients the chemotherapy. And another way to explain this, the study was we have had 1,700 patients together with the Austrian group. When they are stratified regarding the guidelines, the normal European or German, I think the European guidelines, you separate them in 250 low risk and 83 high risk. This is relatively clear, and this works nicely. 5% metastasis, 44% metastasis. So the stratification is okay. But you have an intermediate group, and this is 1,300 patients, and you don't know what to do. And most often they get chemo plus tamoxifen plus chemo. But when you use these assays, then you have 840 low risk and 530 high risk patients. So that this is clinically relevant is shown that here are 4.5% metastasis, similar to that, and these are around 20%. So these patients, these 840 patients do not need chemotherapy. This is the result of this assay, and this I think is very helpful for for the clinical decision how to treat the patient. Okay, this is also valid for after 5 years. This is a very special issue for this assay. In the first five years, the separation is very nice. When you start again the separation after 5 years, it's still working. So it's really a long time valid assay. Premenopausal, postmenopausal, it's functioning equally, and it's in 50% or 46%, 4%, there is a change in therapy regarding when you do this test. So this is done relatively often now in our country. Finally, I would like to have one look into the future with you, exemplified by a current case. We have had a metastasized neuroendocrine carcinoma grade 3, a very difficult disease with metastasis in the liver. We did our standard sequential molecular diagnostics, BRAF, exon, etc. We didn't, as you see here, we didn't do exon 20, for example. No mutation, so we haven't had any possibility, and this is a normal procedure we are doing. But the next step, which now is becoming routine step by step and will be routine, I think, around Europe in 2 years or so, maybe 3 years. This is to have a whole exome analysis. We did this with AI in Torrent, which I think is a very nice instrument. We can discuss this tomorrow a little bit more in detail. And what we found using this panel of 46 genes with 604 loci, we found an EGFR mutation, exon 20, FGFR2 mutation, and a KDR mutation. And all three are trackable. This is the main issue. So the patient now has 3 new possibilities to be treated, which in the normal, with a normal molecular analysis and with a normal, and if we don't do it with a normal morphology, we would have never been able to explore this. So there are really, by using the next generation sequencing procedure, there are new possibilities to treat patients and to do something positive for them. So the final slide, clinical data are always the beginning. All these tests, and this is very important for pathology and to bring pathology also in smaller hospitals, all these tests are done on formalin-fixed paraffin embedded material. It will ever start, I think, also in 100 years with H&E. It's unbeatable. Then immunohistochemistry, of course, estrogen receptor, HER2, only as an example. Then FISH or CIS, silver-Hansen cytohybridization. We will do more and more digital pathology. I didn't show this today because we have to quantify the reactions more precisely. Then the mutation analysis, then point mutations if necessary, then the multi-gene assays, as I explained to you for the breast cancer, and finally next generation sequencing. And I think we will have to do all these techniques really to get as many information out of the tissue as I told you, and this will be this combined morphological molecular access will be the basis of personalized medicine in the future. Thank you very much.